Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, a cardiologist in Houston. I've been practicing for more than 40 years. The focus of this presentation is ACC AHA 2020 guidelines for aortic regurgitation, evaluation, and management. So let us begin with the feature presentation. You can follow my green arrow here. The aortic valve separates the aorta from the left ventricle, and usually the valve is functioning in such a manner when the ventricle squeezes, the blood is pushed into the aorta, but when the aortic valve closes, there is no leak of blood into the ventricle. However, if the aortic valve is incompetent, if the leaflets do not coapt together as they are supposed to, if they do not coapt together, then there may be a leak across the aortic valve. There are a number of conditions that can lead to aortic valve leak, which I'm going to talk about in a minute. Then it's going to have significant effect on the left ventricular size, left ventricular thickness, left ventricular function, and it may also be associated with diseases involving the aorta. So there are a number of factors that we need to look into when we are dealing with a patient with an aortic regurgitation. We're going to go through systematically as how we evaluate a patient with aortic regurgitation and then decide what is the appropriate treatment pathway that we need to follow. Generally speaking, the aortic regurgitation is not found as an isolated event, even though it can be, but it is most often seen in association with other conditions like rheumatic heart disease or patients with aortic stenosis, or if the person has been diagnosed to have bicuspid aortic valve in the past, or through a family history of bicuspid aortic valve or Marfan's syndrome. These are some of the conditions that can be associated with aortic regurgitation. So let us move on to the next slide. And here is the 2D echocardiography, including three-dimensional echocardiography. Transesophageal echocardiography are the gold standard for determining the degree of aortic regurgitation, the quantity of regurgitant volume, the regurgitant fraction, and many other parameters which will enable us to decide as, what is the patient condition. Are we just dealing with a mild stenosis, moderate stenosis, severe stenosis? Is it acute? Is it chronic? And what is the prognosis based on all of these mumbo-jumbo conditions? So here is certain points are worth noting. This is called the neck of this regurgitant jet, which is called the venae contracta, and then we have the flow convergence, which looks like a dome here. After that, we have the jet height, and we also have the jet length, and this is compared to the left ventricular outflow tract to determine the degree of aortic regurgitation. So we have super excellent methods to determine the location of the aortic regurgitation, the quantity of the aortic regurgitation, and the volume of the aortic regurgitation, along with the associated findings in the left ventricle, in the aorta, and many other structures to make a very meaningful judgment as what needs to be done with these patients. As I told you, the aortic regurgitation comes in many different forms. The aortic regurgitation could be a mild aortic regurgitation, which may be found in patients with dilated aortic root, or even a mild regurgitation murmur may be heard in severely hypertensive patients, and aortic regurgitation is frequently seen in patients with critical aortic stenosis. If the leaflets are immobile and if the leaflets don't move and close properly during systole, there could be a mild aortic leak. And in patients with mild aortic regurgitation, if there is no other associated condition, their left ventricular size is normal, their left ventricular end diastolic volume is normal, and the left ventricular end diastolic diameter is going to be normal. You need to pay attention to every one of these sentences I am saying. It is based on 20-30 years of dealing with cardiac patients at bedside, looking at the echocardiograms and deciding what are the parameters that we use to see who has mild aortic regurgitation and who had severe aortic regurgitation. So let me recap again. You are dealing with a mild aortic regurgitation. If the left ventricular size is basically normal, if the thickness is normal, and the left ventricular end diastolic pressure is normal, and you see a mild aortic regurgitation, a slight jet based on the color flow Doppler on the echocardiography. On the other hand, if you are dealing with a chronic severe aortic regurgitation, this is somebody who has whatever the underlying cause may be, we're going to talk about that in a minute. Whatever the underlying cause may be, has moderate aortic regurgitation over a period of many years, which leads to left ventricular volume overload. And as a result, since this is happening over a period of many months and years, this ventricle accommodates that by increasing its left ventricular size. There's an increase in left ventricular volume. There is an increase in left ventricular end diastolic diameter, but with a preserved left ventricular function. So the end diastolic pressure may be mildly elevated, but nonetheless, it is not severely elevated. And they may have some hypertension, which could be one of the causes for elevated systolic pressure, but they have low diastolic pressure. It is one of the hallmarks of aortic regurgitation. That's why we get what is known as the hammer pulse, where the blood regurgitates and there's a sudden decrease in the aortic volume, which leads to this significant drop in the dicrotic notch, causing the water hammer pulse. That's where we put a hand like this and we can feel like that hammer pulse. That's the bedside examination of aortic regurgitation. Okay, now let's talk about acute aortic regurgitation. Acute aortic regurgitation can happen in the setting of an aortic dissection, or it can happen in patients with severely dilated aortic root. If there is some disruption of the aortic leaflets, it can be secondary to endocarditis. And in these situations, when there is significant regurgitation into the ventricle has no time to adapt itself. As a result, the left ventricular size remains normal, but because it is getting so much volume, the left ventricular end diastolic pressure becomes high and it normalizes the left ventricular end diastolic pressure with that of the aorta. And this is a hallmark of acute severe aortic regurgitation. And we're going to find out how we're going to identify patients with acute aortic regurgitation based on echocardiography, pulse Doppler, and continuous wave Doppler and other findings. The features of acute severe aortic regurgitation are normal size ventricle, severe aortic regurgitation, and significantly elevated left ventricular end diastolic pressure. So these are things which are going to help you to identify, because they may give some of these parameters saying the patient presents with acute shortness of breath, has pulmonary edema, and here is the aortic pressure, here's the left ventricular size, here's the left ventricular end diastolic pressure, and there is aortic regurgitation. What is the degree of aortic regurgitation? What kind of aortic regurgitation are we dealing with? Anyway, let's move on. Chronic severe decompensated aortic regurgitation. Remember, when I was talking about this compensated one, I said the LV systolic size is increased, but the systolic function is preserved. The rejection fraction is greater than 55 or maybe even 60%. But when the chronic aortic regurgitation progresses, there comes a time when the ventricle gets much bigger and it leads into left heart failure, resulting in reduced left ventricular ejection fraction. And along with that, there may be a significant increase in the left ventricular end diastolic diameter, which is a poor prognosis. So in these patients with chronic severe aortic regurgitation who decompensate, when they decompensate, that means they don't have the ability to adapt, they don't have the ability to pump the blood forward. As a result, their end diastolic volume, end diastolic pressure goes up, but they have large ventricles, with increase in left ventricular end diastolic diameter, increase in left ventricular volume, and all of these features will help us to differentiate among these 4 different types of aortic stenosis, aortic regurgitation. So we talked about the dilated root, endocarditis, aortic aneurysm, mild, moderate, severe, acute, chronic, and of course you see acute regurgitation in patients with aortic dissection, or in patients with endocarditis, or in sometimes it may be seen in patients with trauma, chest trauma. Okay, how do we diagnose aortic regurgitation and determine the degree of aortic regurgitation? As I told you, the 2-dimensional echocardiography, 3-dimensional echocardiography, and of course TEE, all modalities will be the gold standard in trying to determine the degree of aortic regurgitation. Whenever there is aortic regurgitation into the left ventricle, we see a waveform that is in the diastolic phase of the cardiac cycle, that is in the aortic valve region. The pressure half time is one of the numbers that are used to determine the degree of aortic regurgitation, and I'll bring that up in the next slide to show what numbers represent what. We can look at the leaflets, see if there is thickening, adhesions, where the leaflets are immobile, the calcification, restricted mobility of the leaflets. Then we look at the dilatation of the left ventricle, it should be. Then we look at the pressure half time, which I talked to you. We use a color flow Doppler to look at the aortic jet, look for the venae contracta and the flow convergence and the beam, and see how much it covers, which I talked to you about just a minute ago. As I said, we also look at the left ventricular size, thickness, diameter, and wall motion abnormalities in case this patient has concomitant coronary artery disease. Along with that, if this person has rheumatic heart disease, we look for problems in the mitral valve, pulmonic valve, or the tricuspid valve also. In addition to that, the echocardiography will help us to determine if this patient has already developed symptoms of worsening heart failure with development of pulmonary hypertension. The other test that we could use would be chest CTA to look at the aorta itself, look at the morphology of the aorta, look for aneurysms or dissections, and similarly CMR can also look at the aorta. It can also look at the left ventricular size and thickness and wall motion abnormalities, along with any other things that we might see in the cardiac structure. In old days, in the 80s and 90s when I was practicing, we were taught the early diastolic low frequency murmur is characteristic of aortic regurgitation. If the aortic regurgitation is severe, then this diastolic murmur would be short, because once there is equalization of pressure in the aorta and in the left ventricular cavity, there is no more flow of blood. As a result, the shorter the aortic diastolic murmur, that's an indication that it could be we are dealing with acute aortic regurgitation. But unless you do a phonocardiogram, it would be hard to know. But echocardiography is much more sensitive in determining whether we are dealing with a mild or a severe or an acute aortic regurgitation. I just put that up because that is something that we all started learning. Here, coming back to this echocardiographic features that are used to determine the degree of aortic stenosis. As I said, the size of the vena cava determines the degree of aortic regurgitation. The width and the volume of this jet that is covering the outflow tract. This is the outflow tract of the ventricle. And see here, it's covering more than 50% of the outflow tract. All these things signify the degree of regurgitation. The vena contracta here, and of course the jet area here compared to the outflow tract, which is the area here just below the aortic valve, and same thing with the jet length also. If it covers the entire outflow tract, that's an indication that we are dealing with a severe aortic regurgitation. One of the criteria that is used to say whether the aortic regurgitation is mild, moderate, or severe is based upon just one number here, the vena contracta. That is that neck of the jet. Let's go back here. It is this neck. And if this is less than 3 millimeters, I'm talking about this vena contracta, the neck, less than 3 millimeters. That means it is very narrow. That means we are dealing with mild aortic stenosis. If it's between 3 and 6 millimeters, we are dealing with moderate aortic regurgitation. If it's greater than 6 millimeters, in other words, if this jet is like more than 6 millimeters, like it's twice as nice, if the jet is like this, the vena contracta, then you're talking about severe aortic regurgitation. This is a very important number and a parameter that is going to be used in determining the clinical pathways. That's why I'm spending more time in trying to explain this, even though you may not read echocardiography, even though you may never be able to interpret what the numbers mean, but at least it's nice to know the knowledge. Okay, here is like a diagrammatic representation of what we are talking about. As I said, if the jet is covering only about 25% of the outflow tract, it is 1 plus. If it is covering like 30% of the outflow tract, it is like 2 plus. And as you can see, as it covers more and more of the ventricle, the degree of mitral regurgitation gets worse. So this is a sort of a diagrammatic representation combined with vena contracta and the length of this jet and the width of this jet will tell us as whether we are dealing with mild, moderate, or severe aortic regurgitation. Now, putting all this information together, I talked about the jet. If the jet covers only 25% of the left ventricular outflow tract, that's what it means, then we're dealing with mild. The vena contracta has 3 millimeters, and the pressure half time. If the pressure half time is like 500 milliseconds, it is taking 500 milliseconds to come down. That means we are dealing with a mild aortic regurgitation. And if the regurgitant volume is 30 ml, regurgitant fraction is less than 30%, then we are dealing with mild aortic regurgitation. On the other hand, let's look at the severe aortic regurgitation. Basically, when we are dealing with aortic regurgitation, we need to know what is a mild aortic regurgitation. So these patients can be followed clinically with serial echocardiograms and clinical examination. It is a moderate and severe aortic stenosis that needs interventions. And we are going to talk about what interventions they need. So let's look at severe aortic regurgitation. Width of the jet, 65% of the left ventricular outflow tract. That means 2/3 of the left ventricular outflow tract. I'm talking about here, we have the left ventricular outflow tract, and if this jet occupies 2/3 of that width, then we are talking about severe aortic regurgitation. Vena contracta, more than 6 millimeters, which I already talked about. And if the pressure half time is 200 milliseconds, it takes only 200 milliseconds for the pressures to equalize. That means the pressure in the ventricle is rapidly going up, which is the reason why the ventricle and the aortic diastolic pressures equalize. Thus, the pressure half time is cut short. Then the regurgitant volume is almost twice that of the mild, and the regurgitant fraction is almost 50%. So 50% of the blood that's being pumped into the aorta is coming back. That's an indication we are dealing with severe aortic regurgitation. So knowing these numbers, it will help us to determine how we proceed further. This is a more elaborate way of looking at if you are an echocardiographer, and you can spend a whole day analyzing a patient with aortic regurgitation by getting fantastic images, fantastic pulse Dopplers and color flows, and then decide what is going on. So let us look at the mild one, which already I talked to you about. Vena contracta less than 0.3 and the jet less than 25%, and the pressure half time greater than normal size LV, normal systolic function. That's why I'm giving you the fundamentals that are used in making clinical pathway decisions, so that when you understand the fundamentals, the clinical pathway just becomes automatic. Let's look at the severe case which needs intervention. We have flail valve. Oh, that's a pretty significant indication. Vena contracta greater than 6, 65% of the outflow tract, the jet width, pressure half time less than 200, holosystolic flow, and reversal of flow in the descending aorta. And of course, because so much blood is coming back into the ventricle, you see the blood, instead of going downwards in the aorta, in the descending aorta, you see the flow reversal, flow going back into the other direction. Of course, along with that, we see enlarged left ventricle with maybe normal or abnormal systolic function. And these are all minor variations to look at whether we are dealing with a moderate case, but I would just stick to these two ends, and you can pause the slide and look at it. I just put this one for reference so that if you are an echocardiography fellow, or if you're an echocardiographer, you're interested in echocardiography, you can go in depth and analyze this. Again, recapping, we have early mild aortic regurgitation, which the parameters we talked about. Then we have the chronic severe aortic regurgitation, compensated, acute severe aortic regurgitation, where there is no time for the ventricle to dilate, so diastolic pressures equalize with a normal size ventricle, and of course decompensated aortic regurgitation. I know I keep repeating this because the same parameters are used to the clinical pathways which we are going to look at in a minute. One thing we need to understand about acute aortic regurgitation is there is rapid elevation in left ventricular end diastolic pressure and left atrial pressure. The LV attempts to maintain cardiac output with increased heart rate and increased contractility. Because it is getting back so much blood, maybe more than 50%, it has to pump that blood back into the aorta. It can do only so with increased contractility and increased heart rate. In attempts to maintain forward stroke volume and cardiac output, it may not be able to do so, and if it is not able to do so, then the person will develop pulmonary edema, which is usually a common presentation in patients with acute regurgitation. They can also develop myocardial ischemia due to increased myocardial oxygen demand. If the forward flow is not adequate, they can develop cardiogenic shock. That's why I said this is a medical emergency. We have to make a diagnosis and we have to go to the operating room and try to fix the leak. How often do we need to do an echocardiogram in asymptomatic patients with valvular heart disease and normal LV systolic function? So let's look at for aortic regurgitation here. I kind of highlighted this one. We need to check their echocardiogram. These are the patients who have aortic regurgitation, normal left ventricular function. This is not acute case, so we need to do echo every 3 to 5 years for mildly severe aortic regurgitation. When it gets to be moderate, we need to check the echo every 1 to 2 years. And in case of severe asymptomatic patients, every 6 to 12 months, or if they develop new symptoms, then we need to check an echocardiogram and see if there has been anything structurally. Who are the people who need intervention? We talked about mild, moderate, and severe. It is the moderate and the severe group who are symptomatic who need treatment. And here is a different way of looking at the same information. This is what the American College of Cardiology and the American Heart Association recommends to characterize these patients into stage A, B, C, D. We will be mostly focused on stage C and D because these are the patients who are having symptoms, who are also having findings consistent with moderate to severe aortic regurgitation. And here, as I told you from the previous slide, we need to follow them with follow-up echocardiograms depending upon the severity of the aortic regurgitation. Now let's take class C, symptomatic severe. symptomatic patients who have criteria for normal RV or LV systolic function. So now we are talking about C1 with normal systolic function. C2 is someone with a valvular heart disease with decompensated LV systolic function. So if you are having a chronic aortic regurgitation patient who had a normal ejection fraction to start with, now you see a drop in the ejection fraction, they fall in the category of C2. And finally, D, which is like a slam dunk, a patient with severe symptoms who has decompensated valvular heart disease. Okay, taking all this information now, all this basic information, then we put the whole thing together and say, okay, what are the things that we need to, it's like a cliff notes here. With the echocardiography, we need to know what is the left ventricular end diastolic diameter. That's a very significant index of if the patient is decompensating and going to a point of no return. We look at the left ventricular volume, left ventricular ejection fraction, other valvular heart disease, and 3D echocardiogram, transesophageal echo, CT of the chest, and CMR. When we have all this information and we know what degree of aortic regurgitation is present and what stage the patient's aortic regurgitation is, then the decision becomes fairly easy. I won't say simple. So we are dealing with aortic regurgitation here, severe aortic regurgitation, and all these parameters which I already mentioned. That is why I spent most of the time in trying to make you understand what these parameters they are using. If you don't know what they are using, then this becomes worthless. So we on stage D, I already showed you in the previous slide what is stage D. A patient with severe symptoms, severe aortic regurgitation who has decompensated left ventricle. Class 1 indication is aortic valve replacement. And in symptomatic patients in stage C, if they have reduced ejection fraction, that is a stage C2, which is worse than stage C1, so they also go for aortic valve replacements. If they are going for concomitant other surgeries like mitral ring or tricuspid ring or coronary bypass surgery, then of course they need aortic valve replacement. If in asymptomatic stage 3 patient, if the ejection fraction is greater than 55%, left ventricular end systolic diameter is greater than 50 millimeters. That's an important number which I was talking to. That's a systolic diameter. Now we're looking at the diastolic diameter. So here they mention left ventricular end systolic diameter is greater than 50. Then you consider aortic valve replacement, which is a 2A indication. The same patients, if they have a reduced ejection fraction between 55 to 60% and increase in left ventricular end diastolic diameter of 65 millimeters on 3 studies. I'm talking about this one, greater than 65 millimeters on 3 consecutive studies. If that's the case, then if he's a low surgical risk, you consider aortic valve replacement. Whereas moderate aortic regurgitation, if a person is going for other cardiac surgeries like mitral valve replacement or a mitral annular ring or tricuspid ring or bypass surgery, then you replace aortic valve at the same time because you don't want to come back 6 months later or a year and try to do that again. This chart looks at the mortality rates for aortic valve replacement. If it's aortic valve replacement alone, it is 2.2%. If it's combined with CABG, it is 4%. If it's combined with mitral valve replacement, it is 9%. So this is an important information we want to communicate with the patient and the family before we decide to do the surgery. Okay, we need to talk about valvular heart disease and atrial fibrillation. If we have a patient with aortic regurgitation, and if this person develops, if this patient has a prosthetic valve and develops bioprosthetic valve and develops atrial fibrillation, then after 3 months of the procedure, they can be treated with either NOACs, newer oral anticoagulant agents, or vitamin K antagonists based upon the CHADVAS score. Whereas the new onset atrial fibrillation is within 3 months of the valve implantation, they need to be started on vitamin K antagonist anticoagulant therapy. A couple of words about bicuspid aortic valve. Bicuspid aortic valve is not uncommon. It is seen fairly commonly. Bicuspid aortic valve is associated with aortic regurgitation in 13 to 30% of the patients. About 12 to 37% of these patients have aortic stenosis. It also has aortic enlargement, seen in 20 to 40% of the patients. Bicuspid valve and aortic coarctation go together. If you see these two words in a cardiology board question, they are connected. So that could be a clue that bicuspid aortic valve is usually associated with aortic coarctation. It's prone for endocarditis, and usually it is associated with some type of aortopathy, aortic dilatation, aortic aneurysm, coarctation, and many other things. If that's the case, we need to do, not only echocardiography, we also need to evaluate their aorta thoroughly well. And we need to look at the aortic dimension. If the aortic dimension exceeds a certain number, which we'll see in the next slide, then we have to make some decision. And to this, we can add CTA and CMR to give us much more accurate information about the aortic root size, aortic sinus junction size, ascending aortic size, presence of aneurysms and coarctations, among others. And if a patient with a bicuspid aortic valve with prior aortic valve replacement, then they need to be continued lifelong and looking for changes in their aorta. Chart, which is looking at bicuspid aortic valve. If the aortic sinus or the ascending aortic diameter is greater than 5.5 centimeters, they need replacement of the aortic root along with the ascending aorta and the aortic valve. Whereas if we have an aortic sinus or an ascending aortic diameter 5.0 to 5.5 with risk factors for dissection, then replace aortic sinuses and or ascending aorta during cardiovascular surgery. Indications for surgical aortic valve replacement: aortic sinus and ascending aorta diameter is greater than 4.5 centimeters. If you are dealing with the aortic valve problem and you decide to do an aortic valve replacement, if the aortic diameter is greater than 4.5 centimeters, then replacing the ascending aorta would be an important step in these patients. Similarly, ascending aortic sinus or ascending aortic root diameter is 5 to 5.5 centimeters without risk factors for dissection. Replace aortic sinus and the ascending aorta if performed in low risk patients at comprehensive valve centers. That's what the CBC stands for. So, ladies and gentlemen, this is a very comprehensive review of aortic regurgitation. What are the conditions that cause aortic regurgitation? How do we determine the degree of aortic regurgitation? How do we classify the stage in which the patient is with reference to aortic regurgitation, not only based on cardiac echocardiographic findings, but upon the overall condition of the patient, including that of the aortic root, the aortic sinuses, the ascending aorta, and all other factors, and see what is the most appropriate treatment. How often do we follow them before? How often do we follow them afterwards? And a word or two about anticoagulation if these patients develop atrial fibrillation. Thank you so much for watching this presentation, and please do subscribe to our YouTube channel. We have a series of lectures on ACC AHA guidelines on many topics, and you can watch them. Help you a great deal in terms of deciding what is the best treatment plan based on sound medical knowledge. I will see you in the next presentation.